That was very dramatic, the last session, so it makes me a little bit nervous to speak in front of you because I know you're a very tough crowd and the judges are here again to hear my last talk. In all seriousness, it has been an honor coming to this prestigious meeting. I've been incredibly impressed with the organization, the program, and your speakers. So I just would like to speak this afternoon a little bit about ductal carcinoma in situ. It's very common in the United States, of course, because we do screening mammography. There's a big conundrum about overtreatment of DCIS versus better understanding of the biology of the disease. So in the United States, in 2014, we have about 60,000 cases of ductal carcinoma in situ. And in my personal practice at MD Anderson and in the country, this represents a large number of women we're treating for breast cancer, about 25%. With the introduction of mammography, we really started to have much more diagnosis. In fact, since we introduced mammography, it has increased 500-fold in incidence. So that is part of the reason why we're concerned that we may be overdiagnosing and overtreating. During the last decade or so, we're trying to get a little bit better understanding about the biology of DCIS, just like, of course, invasive breast cancer. And you might wonder, why am I showing you a obviously locally advanced breast cancer, but we've had such good experience with preoperative chemotherapy in beginning to understand the biology of invasive breast cancer. It was felt that, in fact, why not try different agents preoperatively for ductal carcinoma in situ? Certainly, it allows for an in vivo assessment of response in the patient. And this way, we may be able to determine the molecular predictors of response and perhaps better understand not only the biology, but expedite better drugs that might be needed in lieu of surgery and/or radiotherapy. Well, breast cancer develops over time and may take actually sometimes decades, but what we know for in the atypical ductal hyperplasia, we can give anti-endocrine therapy such as tamoxifen and reverse the incidence of developing invasive breast cancer. So the question is, can we at the DCIS stage prevent or reverse the process with various agents? At University of California, San Francisco, they began to do this and to look very carefully at this in these groundbreaking trials. As you can see, patients with ductal carcinoma in situ, which was ER positive, biopsy proven, of course, had a baseline MRI. This was followed by 3 months of letrozole in postmenopausal women or tamoxifen in premenopausal women. In this study, they very clearly showed a marked reduction in Ki-67, as you can see, the proliferation, and a marked improvement in immune cell, that is mononuclear cell or macrophage infiltration into the DCIS lesions. The reduction in proliferation was seen both in premenopausal and postmenopausal women. This is just some of the MRIs from the UCSF group showing pretty dramatic response. There were very few complete pathologic response, but in this particular situation, there was. So what did they learn? They learned that preoperative endocrine therapy was safe and that we could actually see histologic as well as immune changes in the ductal carcinoma in situ. None of this means that we can just go ahead and treat patients with anti-endocrine therapy in the absence of surgery. But there's a big interest in this among our patients as well as physicians. This slide shows the National Cooperative Group Alliance trial. Women in this trial are very similar. In fact, the principal investigator was from University of California, now at Duke, Dr. Shelley Wang. And as you can see, instead of 3 months of letrozole, they're giving 6 total months. At the 3rd month, They again look at MRI. If there's any progression, of course, surgery. But in this study, which is accruing very well, it is opening the door to potentially identification of certain subsets of patients where we actually could go ahead and just observe, like we do for atypical ductal hyperplasia and other high-risk lesions. I call your attention to another trial that is opened in the United Kingdom. This is called the LORIS, L-O-R-I-S trial, and it's very much like the active surveillance program for prostate cancer, which actually was pretty common in Europe. And this patient group are screen detected low or intermediate grade DCIS. Women over 46 years were randomized in a non-inferiority trial of 932 patients, with the primary endpoint being invasive breast cancer, secondary meaning freedom from mastectomy. So this is very interesting. I know from the organizers of the trial that women will not even be allowed to take endocrine therapy. So this is kind of where we're moving. The pendulum is swinging the opposite direction. I show you this trial, which we initiated really in 2005, looking at Trastuzumab and DCIS. It sounds kind of, when I look back, it was kind of a bit of a crazy trial that is giving more and more drugs for ductal carcinoma in situ. But we really felt that DCIS was the perfect entity to give a Trastuzumab or anti-HER2/neu therapy, because the toxicity when giving alone is pretty minimal because it's just a monoclonal antibody. What we found is that HER2 amplification was very high among patients with DCIS, so it seemed like this might be the best group of patients. Our hypothesis was that among ER-negative, HER2-positive DCIS, short treatment with Trastuzumab would eliminate the development of invasive HER2-positive breast cancers. In this simple study, patients had a core biopsy showing HER2 3+ or amplification. They were given 1 month of Trastuzumab and then surgery. As you can see from this slide, the size of the DCIS was very large. It was 5 centimeters. This was because patients were more likely to be going to have mastectomy with reconstruction, so they didn't have to delay waiting for their surgery. In this study, there were 24 patients who had HER2-positive disease, and 12 patients who did not undergo drug treatment served as the control. The study was designed to look at the immune response in these patients, as well as classic markers of apoptosis and proliferation. Although it was a small study, there was absolutely no change in proliferation. There was no change in apoptosis, no histologic changes in short treatment, but there really was a pretty remarkable immune response, which was demonstrated in every one of the patients, where there was antibody-dependent cellular cytotoxicity after treatment, but not before in these patients. And this was mediated by the patient's own natural killer cells. So this was kind of exciting. However, it did appear that it might not actually be effective, particularly as we look at now other HER2/neu blocking agents, such as Pertuzumab. When we look at the neosphere, this is, of course, invasive breast cancer. After 4 cycles of Trastuzumab and Pertuzumab, 17% of the patients had complete eradication of invasive breast cancer. So it still opens the door to perhaps that this might be a potential treatment for DCIS, but I think that certainly more study is needed. Now, I just want to talk to you a little bit about some interesting vaccines for DCIS, and these slides are from my colleague Brian Cerniak at the University of Pennsylvania, where they're doing quite amazing studies. To me, this is kind of like science fiction. The patient with ductal carcinoma in situ has her blood drawn, and the monocytes are actually treated outside of the body, ex vivo, with HER2/neu peptides to stimulate them. Next, those cells are injected back into the same patient. What's interesting here is the vaccinations are into the lymph node on the side of the DCIS. What they found in these very exciting studies is that there is great infiltration of, in this case here, T cells after treatment in these lesions. And many of the patients where they were able to look at the blood up to 2 years later, the immune response was still effective. So it's making us think that perhaps it might be some way actually not only to treat disease, but it also may be a way to prevent recurrence. What about other drugs? Of course, any drug could be used for DCIS, but LAPatinib has been of interest to us at MD Anderson, mostly because of a mouse model of DCIS with treatment in these transgenic mice. There were significant effects with the LAPatinib for this model in mouse. This led to a multi-center trial, which is being run by my colleague, to look at the effects of LAPatinib for DCIS as well. So I think we've entered a new age that is another paradigm, moving the neoadjuvant or preoperative approach into ductal carcinoma in situ. You can imagine that there's certainly several other drug potentials that could be given, mostly with low toxicity. Utilizing this technique, it may allow for more rapid identification of alternatives, and it sets the stage for potential no surgery and just monitoring of these patients. Thank you again for your attention.